I'm going to be talking today about how do we handle medical burnout in the context of type 1 diabetes by using motivational interviewing. Um, the focus on this talk is going to be with that adolescent age range. That's because where I tend to use it the most in my practice, but it's really applicable to a lot of different ages. You can use it with adults, parents. Um, I'm going to be focusing, like I said, on type 1 diabetes, but it's also really applicable with a variety of different presenting concerns ranging from substance use, obesity and weight management, other chronic medical conditions, and then just kind of general behaviors. I have a lot of patients without diabetes that I use it with, homework, chores, getting into trouble behaviorally. And so that's really where it's most applicable. And so as we're talking, I just encourage you to be thinking about your own practice, whether you're medical or mental health, the kind of patients that you work with. The cool thing about motivational interviewing is it can be used in really brief encounters. So even if you only have 15 minutes with the patient, there's skills that we're going to talk about that you can use. So the goal, so I don't have any disclosures. The objectives for this talk, like I said, I'm gonna do a brief overview of diabetes and diabetes burnout, and then we'll get into some more therapeutic skills to use in clinical settings. We'll understand the spirit of motivational interviewing and how we use it in clinical settings, and then hopefully by the end you'll be able to practice skills to reduce resistance and then elicit change talk in patients. And if you have any questions or thoughts as we move along, feel free to put it in the chat. And I asked Paige to just interrupt me if a question pops up because I probably won't see it right away. So general diabetes cares. I know some people in this talk might come from a medical background. So if that's you, then you can kind of zone out for a couple minutes. I do find it to be really helpful to talk in general about diabetes because not a lot of people are very familiar with kind of the day-to-day burden that diabetes can bring on patients, especially in this teenage age range. I've had some patients come to therapy who said that they had therapy in the past, but didn't really find it as helpful because their therapist just wasn't very familiar with the disease. Um, and we actually do some outreach and education with mental health therapists in the area through diabetes clinics. So if you work with a patient with type 1 diabetes and you want to learn more, or type 2 diabetes actually, and you want to learn more, you can always reach out to clinic for some support and guidance in that. But generally, type 1 diabetes is an autoimmune condition that results in the pancreas no longer making insulin. So your body develops an immune response to the cells that create insulin, and so your body stops making it. And so the result of that means patients with diabetes are 100% dependent on getting insulin from external sources. Insulin is what we need to be able to use sugar in our bloodstreams for energy. So if you don't take insulin, then blood sugar in the bloodstream, or then your sugar in the bloodstream will increase, which can result in a lot of medical complications, both long term and short term. So patients with diabetes are required to check their blood sugar and monitor it multiple times a day, whether it be through a finger poke or they can wear a continuous glucose monitor, which is the device that they wear on their skin. It does blood sugar checking every couple minutes, and then it can send it to your device, and it'll alarm you if you're going too high or too low. So they have to take, like I said, external sources of insulin, whether it be through a shot or through an insulin pump. That means that anytime they consume carbohydrates through food, they have to take insulin to counteract those carbohydrates so that their body can use it for energy. If their blood sugar is going high because there's kind of natural glucose in the blood, they also have to take insulin for that. And then when they eat, they have to count all of their carbohydrates and then use a calculation to determine how much insulin is required for that meal that they're eating. And that calculation can vary depending on whether it's breakfast, lunch, or dinner. So as you can see, it's a lot of moving parts, a lot of things that constantly you have to kind of be thinking about. Um, there have been a lot of great technological advancements in recent years for diabetes. So patients, you can use shots or insulin pens to take insulin, which would mean multiple shots a day. Or you can wear an insulin pump, which is another device that you put on your skin. And it kind of gives a steady trickle of insulin throughout the day. Most recently, they've made these devices Bluetooth. So the glucose monitor can talk to the pump and tell you where your blood sugar is, tell it where the blood sugar is, and then it'll automatically give you some doses of insulin to bring it down or back off if you're going low. So a lot of, like I said, a lot of moving parts. Those technological advancements have been wonderful for a lot of patients. But as you can see, even on your best day with the best technology, there's still that burden of ensuring that everything is hooked up and that the pump is charged, everything's working, there's insulin in there. The insulin pumps need to be changed out every 2 to 3 days, and you have to kind of put them in different parts of your body so that your skin doesn't, so you don't get developed skin complications from that. Um, and for a type 1 diabetic, if you go too long without insulin, it can result in a chemical imbalance called diabetic ketoacidosis, which can result in death. So it is a life-threatening condition if you don't take insulin. And then long term, if your blood sugars are too high, it can lead to, as we know, a lot of significant complications down the road as well. So there's a lot of concerns, as you could imagine, that come up when working with patients with this disease. In my practice, here's a list of some of the most common ones I tend to see. Family conflict is a big one with teenagers. You see, when kids are diagnosed at a young age, parents tend to be the primary caregivers and they do all of the cares. And then obviously when kids grow up, they do all the cares. And so in between that, there's this period of adolescence where there's this transition taking place where parents might want the teen to take more responsibility, where the teen may want to just live their life and hang out with their friends and do what they want to do. And so that can create a lot of conflict. Fear of hypoglycemia is another concern that comes up. That's when the blood sugar goes too low, that can also result in really serious complications, and it can happen pretty fast for some people. So some patients with diabetes have that fear of going low, particularly in their sleep. And the cool thing is the continuous glucose monitors do have alarms that go off and can wake you, but there's still kind of that worry for both parents and patients as well. There's a social stigma for diabetes, really whether it be type 1 or 2. A lot of patients might feel embarrassed by the disease. They might cover up their devices. They might wear clothes so people don't see them. I've had a lot of patients who don't tell their friends about it, which results in them not taking care of their diabetes when they're around their friends. So they'll go to lunch and not eat, or they'll eat and not take insulin, and then they'll be really high the rest of the day. And so that can cause complications as well. Tons of our patients might have insurance or financial difficulties. A lot of patients, insurance companies might say they're going to cover their glucose monitor 1 month, and then the next month they might not, and there's a lot of reasons for that, but that's just kind of a common concern, is people are frequently having to get prior auths and make sure that things are being covered. Insulin's really expensive. And then diabetes burnout, which is going to be more the focus of this talk. So diabetes burnout is a condition that affects over a third of all patients with diabetes have identified it as a barrier to their care. That was among adults, and with teenagers, it can be higher than that. Usually when I meet with patients, I'll define the research, the literature in diabetes burnout kind of has three components to it that they've kind of identified. The first is kind of just being exhausted by the disease. The second is a sense of detachment or apathy, where we just want to kind of stop managing it or forget we have it. And then the third is a perceived loss of control, meaning patients might feel like no matter what they do, no matter how much insulin they take, their numbers are still high, they still don't feel well. And that can lead to a lot of burnout as well. This is actually the most common in adolescence because it's a period of a lot of growth, a lot of hormonal changes, which naturally are just going to cause more fluctuations in blood sugar. So a lot of patients in this age range might do everything correctly. They might take all of their insulin and follow it by the book, but their numbers are still going to be high. And so that can be a significant barrier. And a lot of patients get burned out when they're having to do that day in and day out. I wanted to include this slide just to make sure we're differentiating between burnout and then depression. And then there's a third construct called diabetes distress, which is an emotional distress that individuals with diabetes experience just due to the daily challenges of managing the disease, all of the components that I mentioned earlier. Upwards of 40% of people with diabetes might experience this. And distress and burnout can affect people at different times in their life. So they're both very common. Distress, the diabetes distress is not a DSM diagnosis, but it can be assessed using some validated measures that we actually use in our diabetes clinic. It's really important to differentiate all of this from depression itself, because obviously when a patient is struggling with depression, there's certain treatments that we use for that, psychiatry, CBT, ACT, those are kind of my go-to. The prevalence of depression in patients with diabetes is about 3 times higher than in patients without diabetes. So it's a lot more common, and they can really overlap, but they're also distinct from one another. So with that meaning, people can have burnout without being depressed, which I see all the time. And similarly, patients can have depression that isn't about their diabetes at all. So we don't want to just assume that a diagnosis of depression is automatically related to diabetes. These are people, they have a whole life, right? And it's not just diabetes, but they can overlap. So the motivational interviewing, which we're about to get into, is more how do we help with the behaviors that are really affecting burnout and kind of perpetuating that. So some people might be a little familiar with motivational interviewing. I always like to start by providing this definition by Miller and Rolnick. They're kind of the initial developers of this. As a specific type of collaborative, goal-oriented communication designed to strengthen an individual's motivation for and movement towards a specific goal by eliciting that person's own reasons for change. So the focus of this is that it's a very collaborative, goal-oriented type of communication, where patient and provider are kind of on the scene on the same level, and actually the patient is viewed as the expert on themselves. A lot of times we see the word interview and we think of it as kind of this hierarchical exchange of like question and answer, like a job interview. But really the word interview here is, you can divide it into the inter and view, and see it as two people on the same level looking together at an issue and then working on a common goal in a collaborative way. So that's kind of unique, I think, to this, is that it's the patient is viewed as the expert and it's very collaborative in nature. Okay. In other words, it's really all about eliciting the patient's own reasons for changing and for taking care of themselves, not installing our own. This can be very challenging for people in our field, whether it be healthcare or mental health, because we're helpers by nature. We know the consequences of not taking care of ourselves, or of a diabetic not taking care of their diabetes. But and it can be particularly challenging for teenagers when we're working with teenagers, because of that idea of adolescent egocentrism, because adolescents developmentally kind of tend to think that they're invincible. And that doesn't go away until the prefrontal cortex develops at the age of 25. So there's this whole age range where a lot of teenagers will have this developmentally appropriate belief that they're going to be fine, and diabetes is not going to affect them long term, and they can just kind of do what they want to do. And so that's another thing that can make providing care for these individuals more challenging. But that's also why, in my opinion, I think motivational interviewing really is perfect for this age range. The goals, I mean, it gives them choices. It allows them to think about their own goals and values. It might be a different approach from anything else that they've experienced from parents, other providers, teachers. The idea being, like, we don't argue with them about whether or not they're invincible. Rather, we find ways to use their own values to help them achieve some shared goals, kind of helping them get what they want. And so I always try to approach them in a different way than other adults may have approached them, because that is just kind of where we can get the most benefit. So how do we go about doing this? The goal of this talk, I'm going to talk about kind of the 4 stages of motivational interviewing, starting with some therapeutic skills, some really simple therapeutic skills, and then going into focusing, how do we focus the discussion on diabetes, and then how do we really get at the meat of motivational interviewing, which is this idea of evoking or eliciting the patient's reasons for change. And then we'll briefly discuss the planning or goal setting stage, which comes at the very end. So I think a lot of people here are probably already very familiar with these therapy skills. Anyone who works in mental health would have already had training in it, and I imagine a lot of medical providers would as well. But I still think it's really good to highlight because this is really the foundation of MI is getting patients engaged and making sure that there's that good therapeutic relationship. So we want to highlight making sure to use open-ended questions. Really, a huge component of MI is that the patient does most of the talking, which for some patients can be kind of challenging. And so you just get way more information when you ask, tell me how you did taking your insulin, as opposed to, did you take your insulin, right? Affirmations are important. That I like to make sure to differentiate that from the idea of praise. So when we praise somebody, there's that hierarchy again. So it's like, good job, I'm proud of you, right? Whereas an affirmation is more highlighting the patient's like value or what they did. Um, this must be really important to you. You've worked very hard. I can see how much you value your health. Those are some good affirmations that really get the patient aligned and engaged. Reflection statements, or think of them as verbal highlighting. So just repeating back exactly what the patient said, just another way to relay that you've been listening to them. And then I love summaries. It's more of a synopsis. So it relays that you're listening, but also understanding. And in medical settings, I think when patients come in and just unload a lot of information at you, I think it can be a nice way to just summarize what they said. And then it's nice when you're not really sure how to respond when they have a lot of stuff going at you. So I would encourage everybody to be very mindful about how they're using these in their clinical encounters. And because then that's kind of how we can go to the second step, which is focusing the conversation. A lot of people might glaze over this, especially when we only have a quick, 10-15 minute encounter. But it's so important. So just a couple anecdotes. I had an experience once where a female patient was at her diabetes appointment and she was on her phone, and we were trying to talk about her A1C, her blood sugar levels, and kind of develop goals and kind of help her get things back under control. And she just was pretty shut down. And it came out later that she was kind of actively being bullied on her phone during the encounter. So people were messaging her, or I think she was scrolling Instagram and seeing posts that people were making about her. And so obviously she wasn't in any kind of a mindset to be focused on her diabetes in that moment. And it really, you have to make sure to kind of pay attention to body language and things, and really make sure that you address that patient's concern first. For teenagers, maybe they have a test later in the day and they're worried they're going to run late at the appointment and miss it. Maybe they're feeling sick, they didn't get any sleep, they had a breakup the night before. So there's just a lot of things. It's worth addressing and then shifting to diabetes. It doesn't need to take very long. It only needs to take a couple of minutes, but it's good to kind of go in and offer a menu of discussion, make sure you address their needs, and then shift it to diabetes just as another way to keep them engaged and avoid them shutting down. So the third stage, so to speak, this is where the real meat of motivational interviewing lies. I'll go over each of these a little more, but generally what we do in MI is we use those OR skills to get people engaged, empathize, and then as we're talking, we want to develop a discrepancy. And what that means is patients will talk. You want to develop a discrepancy between where they are right now and where they say they want to be, or where they say they are. Okay. So for example, a patient might tell you that they've been taking all of their insulin, but you're looking at their glucose or at their CGM, their continuous glucose monitor output, and it has everything sky high. So that's a discrepancy. Okay, you're saying you're taking it. Help me understand, because your CGM shows that your numbers have been really high, and that can help break that kind of barrier of resistance. You want to really just approach it with curiosity, and so that's why I always use that. Help me understand this. You say you want to play soccer and you're passionate about it, but your numbers have been so high that you've had to sit out a lot of practices. Help me understand that. And that can kind of get people talking a little more about what they want and come up with their own reasons for why they should make some changes. Another key component that we'll get to later is this idea of rolling with resistance. So resistance is going to be there. So we can always assume that people are going to be resistant on some level. And so So what the goal is to make sure that we're not resisting back. So we don't want to get into arguments with patients. We don't want to lecture patients. This isn't really the time for that. There's an idea of acceptance versus approval. So we can accept that somebody is not doing anything good for themselves. They haven't taken insulin very much at all in the last few weeks. We can accept that that's where they are without approving of it. And so that's a good thing to make sure we're highlighting, especially with parents who come in frantic, is, I'm not approving of it, but I am accepting that that's where we are, and that's just how things are right now, and we can build off of this. And then, of course, we want to support self-efficacy. That's a huge component of motivational interviewing, especially with teenagers. That goes a long way, where we give them autonomy. It's the difference between, if you want, I can help you get better, as opposed to do this now to get better, if that makes sense. So next, I want to go over the motivational interviewing. The goal is, when we have patients talking, we want them to engage in what we call change talk, which, as you can see, is the exact opposite of resistance talk. Change talk is kind of defined as really anything that the patient says over the course of a conversation that encompasses perhaps a disadvantage of the way things are going, an advantage of changing, or intention or optimism about change. And as you can see, resistance talk is the opposite of that. Basically, what we want to do as we're having a dialogue with a patient is really reinforce and build up and have the more percentage of that conversation be change talk and less of a percentage being resistance talk. Okay, so a few examples of this might be, if a patient says, I'm tired of feeling sick when my numbers are high, which is a good example of change talk. It's a disadvantage of the way things are, versus, I don't really feel anything when my blood sugars are high, so there's no need to take insulin. And for them, that's an advantage of right now, is I don't feel sick, so why should I take insulin? Which is a very common thing in adolescents because their bodies are compensating so much for the high blood sugars. Another example would be, if I took insulin, maybe my parents would let me drive my car again. That's a good advantage of making a change. As opposed to taking insulin would mean always having to carry around my diabetes bag, and I hate that. Okay, so that's a disadvantage of change. And we would want to really reinforce that first thing, the change talk. Okay, and I'll kind of come back to this as we go along, but this is just something to keep in mind as we're going. There are several ways to elicit change talk from the patient. These are some of the most common ones. My favorite is that importance ruler, where we ask the patient, so if you were to rate how important this change is to you on a scale of 1 to 10, where would you put yourself? And there's so much data you can get from that. So if they say they're 7, 8, or 9, great. There's not a lot we need to do as far as building importance for them. Like, they already kind of see this as valuable. Even if patient says they're a 3, then you could come back and ask them, okay, so tell me why you're a 3 and not a 0. And when you do that, when you ask it that way, they're talking about why they're a 3, which is on the higher end of 0. So they're talking about, they're naturally going to be using change talk as they answer that question. You could also ask, why are you, what would it take to go from a 3 to a 6? And once again, they're building up. And so they're thinking, okay, they're talking about using change talk to identify what would be different if they were a 6. Okay. It's good to always ask them to elaborate. So, what specifically is important to you? What specifically is it that makes you identify as a 5 on that scale? Querying some extremes. So, for an example, what are the worst things that could happen to you if you continued what you're doing? Their answer is obviously going to be a disadvantage of the status quo. What's the worst thing about what's going on now? You're just asking them to answer that. What's the best thing that could happen to you if you made a change? What's an advantage of changing? You can look forward and backwards. So how is your life different last year when your numbers were in much better control? What were you able to do then that you can't do now? Or what do you want to do in the future that you can't do now because of your numbers? You want to drive, you want to go away to college. Let's look forward. And in doing that, you can get them to kind of think hypothetically about their future. You can explore their values, and use those values to elicit more and more of that change talk. So I included this slide in here, kind kind of derived from that importance scale I mentioned. I think this is a really helpful strategy just to help identify what kind of patient you're working with, and that can help you determine where to go next with whatever intervention you're trying to do. So this is what I always do towards the end of my appointments is I'll ask people that importance scale on a scale of 1 to 10, how important is this to you? And then on a scale of 1 to 10, how confident are you that you can make this change? Just with those two responses, you can get a lot of good information. So if a patient scores low on both of those, in other words, they don't care and they think they'll fail if they try anyway, that's a good time to really fall back on that empathy, those OR skills I talked about, highlight past attempts at trying, maybe use a gentle challenge on that assumption that they don't care. I always try to follow an assumption that everybody on some level cares about their health and their happiness. And so that's where you can kind of maybe try to challenge that a little bit. If a patient scores low on importance but high in confidence, it's easy to do. I just don't care. Those tend to be the more challenging patients. But what we know is when they're like that, we don't want to provide any more education because they're not ready to problem solve. So instead, we want to use those skills to elicit change talk and then develop a discrepancy, like I talked about before. When patients say that it's important to them, but they don't feel it's possible, they don't feel confident about it, that would be a good time to look into problem solving barriers, maybe providing some education, getting the family involved, doing whatever you can to support building that confidence up. And then obviously, if they're high on both of those scales, that's where you can really start working on setting some goals and making a plan to kind of help them take steps towards being healthier. So when we're eliciting change talk, it's actually a lot more important than eliciting it is how we respond to it. It's really easy in the course of a conversation to kind of glaze over even a snippet of change talk. So maybe they just come in and they say, they're frustrated because their parents dragged them here today. And that is actually a disadvantage of the status quo, but it's really easy to kind of glaze over that. And so we want to ask for elaboration. We want to kind of reinforce, like, yeah, it does seem like you do sound frustrated that you have to be here today. Because your numbers have been so high lately, we've had to have more frequent appointments. What would you like to do to maybe change that? And so we want to respond in a way that's going to keep them talking, focus on that change talk, and really reinforce it. That is a really important aspect of this. But I always want to make sure to say, we have this patient. I don't know about all of you, but everyone's had this level of resistance. I hate you. Leave me alone. I hate everybody. I don't want to talk about this. And actually, I think that resistance is probably the most powerful thing about motivational interviewing. It's a really, really big opportunity to really get some change happening. So I actually love working with a talkative, resistant kid because there's just a lot you can do with that. It's an opportunity. It's where motivational interviewing has the most power. It's good to remember that the patient, when they're voicing resistance, they're running through a script that they know by heart. So they've probably had this conversation 100 times with their parents, with their teachers, again with their parents, with different providers they've seen. And we don't want to be a part of that narrative. Okay. We want to ask ourselves how adults have responded and then do something a little bit different. So the key component here is, like I said before, we don't want to resist back or argue. We don't want to commiserate with the patient. So if they say that their parents won't leave them alone, we want to maybe just reflect the feeling. It sounds like it's hard having your mom look over your shoulder all the time. How do you think you could convince her that she doesn't need to do this? So we're not sharing in their misery. We're just kind of trying to shift the focus a little bit. I have on here, you can do a reflection with some exaggeration, but this is something to do only if you have really, really good rapport with that patient. An example might be, they're complaining about their parents always being on their back, and you could say, okay, well, it sounds like you might be better off without a parent. That obviously you can see how that can backfire. But for a lot of patients, it'll add a little levity. They might laugh and say, no, that's not what I mean. And then boom, you can pounce on that change talk, right? When people are being resistant, we want to shift the focus. So, every time I try this, I fail. What's the point? Okay, well, tell me about the times you tried. What motivated you then? Okay, so we're just shifting the focus from the negative to the positive, right? A good reframe, right? I've tried so many times and failed. Oh, well, this change seems like it's really important to you because you've tried so many times. Why is it so important to you? Once again, that's that change talk that you're eliciting. So you can always turn resistance into an opportunity, um, instead of feeling like you're spinning your wheels working with a resistant patient. So I have here just a few things we want to avoid. Um, Obviously, the question and answer trap, that's something just generally in therapy we like to avoid. That's why we use open-ended questions. But along with that, we want to avoid walking in the room and pretending that we're the expert. I always tell people, and teenagers love to hear this, that they really are the expert on their body. They're the expert on their diabetes. They know more about their diabetes than anybody else. Even if they're not really adhering to it, it's their body. And so when you can make sure to highlight that, I think that can really help a resistant kid get more engaged. I've had a lot of success with that with some patients. We want to avoid taking sides. If it's between a patient and their kid, no matter whose side you take, you're going to tick off the other person, right? Um, I hate labels. We already know this in mental health and in medicine, right? We don't like to label people. Um, I I generally don't like the term non-compliance because there's some connotations that it's like the patient's fault or it's behavioral. I like the term adherence when we're talking about how they're doing with their diabetes. So they're not adherent with their diabetes regimen. It's just a little more objective, and thinking about the medication isn't getting taken. We're not going to blame or label whose fault it is. It's not getting done, right? Um, and then similarly, I don't like describing patients as not caring. Sometimes it's really hard not to do that, but because there's some patients that really seem like they don't care about their health. But our role is to really figure out what they do care about, because everybody cares about something. And when you can figure out what they care about, whether it be their friends, driving a car, getting a job, going like moving out of state and never seeing their parents again, right? That's something that you can work with, and bring it back to their health. Um, so so those are just things to kind of keep in mind so that you don't kind of hit a dead end. And then I also premature focus on the problem. I included that in here. That just goes back to making sure that we're meeting the patient's needs before we dive in and just talk about their diabetes. They might not be ready to do that. So lastly, we have the last stage, which is the planning stage. And this is just like goal setting in any other therapeutic situation. But here's some signs that patients are more ready to do that. Generally, if you jump in and set a goal before they're ready to engage in that conversation, you're not really going to get anywhere. And I know this can be difficult in like a 15-minute doctor's appointment or a really brief encounter with a resistant kid. But it's just good to at least use empathy, and if you can get them to at least be less resistant and more engaged in the conversation, then you can set some small goals. The timing of this really is key, and it's good to just kind of watch for body language and just before you dive in and start goal setting with patients. Um, I included, before we wrap up here, this slide on SMART goals. I think most people are already familiar with this, but in the diabetes world, I love SMART goals because generally diabetes goals can be very, very smart. Okay, using that acronym. So a goal we might set in our high risk clinic would be, little Johnny's going to take his insulin with breakfast and lunch every day for the next week. Okay, so that's very specific. We can measure it at the end of the week. Did they do their insulin, breakfast and lunch? We want to make sure that these goals are achievable. So if a patient comes in and they're not doing any insulin at all and they're just like barely getting by taking insulin, every other day, then they're not going to be successful if you set a goal to just take their insulin all the time. Take it 6 times a day, right? That's not going to be possible. I have a lot of patients where we just start with, let's just wake up and take it first thing in the morning. When you're high in the morning, take your insulin, and that's going to be your goal for the next week or the next couple weeks, and then we'll reassess. So make sure you're achievable, and then you can always build up. We take baby steps. And you can kind of get the idea, time limited. It's good to make sure, we want to just make sure that these goals aren't super vague. So I wanted to leave some room for questions and discussion. I do have, we can talk about some case examples or common issues that I've seen specifically with these patients. But if people have questions, I don't know, Paige, if there's anything in the chat.
We don't have anything in the chat or in the Q&A.
Okay. No questions. Um, anyway, I just think I would encourage everybody. I know I kind of went through that a little quicker than I meant to, but I would encourage everybody to be thinking about their own practices, the patient populations they work with, and then just as you go about your day, your afternoon today, your day tomorrow, just kind of see if you can use little examples that we went over. Like just take the importance scale, and I'm going to see if I can practice that with a couple patients. Or if you're kind of out of the practice of asking open-ended questions, be mindful of that and try and rephrase into more open-ended questions. And that's really where you can get really good at this stuff, is just practicing day by day. And if you work in a clinical setting, there's a lot of opportunities to do that.
Okay. Well, thank you, Genevieve. If there are no questions, I don't know if you wanted to share the case studies that you had, or if
Yeah,
you just, okay.
I can go over, because I gave this talk previously with some nurses in our diabetes clinic, and these are some very common examples of situations that nurses or social workers in medical settings might walk into. And it's kind of, where do we go from there? And so if you've ever had these experiences, I think they're pretty common in pediatrics, right? So you walk in and the parent and teen are just arguing. There's a lot of conflict in the room. That's where, it's best to provide some common ground. And I always ask patients, okay, so if they're fighting, they're in conflict, right? I always just go back to the kids. So I know you want to be healthy and happy, right? And then you ask the parent, you want your kid to be happy and healthy, right? And of course the answer is yes to that. And so then you can take a step back and remind them, so you are actually on the same team, even though it doesn't really feel like that right now. We're all on the same team, and we need to really come up with some strategies to promote Johnny being happy and healthy, which isn't really where we are right now. There's a lot of different ways you can try and reduce conflict, but usually with a parent and teen, it's just kind of getting them a little bit more aligned on the same page. Um, a lot of times, unfortunately, in our high risk appointment or just in general diabetes clinic, you'll walk in and there's tears. There's a lot of crying. People are just very, very burned out. They're very frustrated when they get lab work back and they see that their hemoglobin A1C is higher than they expected it to be. The hemoglobin A1C is a lab that looks at the average blood sugar over the last 3 months. And so if it's higher than expected, that can, be really emotional, especially for teenagers who really perceive that they've been trying. They've really been trying to do well for themselves and their diabetes, but because of all these other factors that are kind of outside of their control, their numbers are still high. And so, walking in and it's really important to use empathy there. It looks like you've had a difficult appointment. You're nervous about how your appointment might go. Just by being here, you're making a positive step, and your doctor is going to come in. They're not, no one's going to lecture you today. No one's going to be mad at you. We want to remind people that their hemoglobin A1C is not everything. So the downside of this particular lab is, sure, it gives an average of their blood sugar over the last 3 months, but I never set a goal to bring down A1C. That's never a goal. A goal is also you never want to tell a kid, okay, come back and let's see if we can lower your average blood sugar by 20 points. That's not a goal because, like I said before, a lot of times that's not really in their control. When we have all these other factors that can affect their blood sugar, a more appropriate goal is going to be those SMART goals that are very behavioral in nature. And that can be a new thing for parents and patients. Usually when I ask a patient what they want their goal to be, the first thing they say is, I want to bring my sugars down. And so you have to take a step back and say, okay, how do we do that? Come up with some behaviors for me that can result in lowering your blood sugar. And that gets them thinking, and sometimes they even need a little bit more help there. We have to take insulin, sure, we have to count our carbohydrates better. Maybe you're not changing your pump site out as often as you need to, and so it's expiring. And so those are some really specific behaviors, as opposed to just this really vague, I want to lower my A1C or lower my blood sugar average. So when people are upset in the room, you want to highlight those small steps that they can take, have them focus on one insulin dose at a time. Sometimes when you're so incredibly burned out, it can be so hard just to do one insulin dose. And then the idea of having to do it 5 times a day can be overwhelming for people. And so we want to try and empathize and just highlight the small steps that they can take, and every time they do one bolus with their pump or one shot of insulin, it's a step in the right direction, and that's a win. Okay. um, the next one here, if a parent seems shut down, like they want to give up, or if the parent seems defensive, sometimes parents will seem defensive, and usually it's like their perception is that people are kind of blaming them. And so what I always want to say is, I know you love your child and you're very worried about them. It can be very difficult to see your child struggling with their health. For a lot of parents, it was a lot easier when their kids were young and they had complete control over it. And now we're asking parents to relinquish that control. Um, Even if it's appropriate for their child's normal need for autonomy, that can be really scary for parents and really, really challenging. So we want to really empathize not just with the patient, but with the parent as well, because they're also very new at this. They may have never had a teenager with type 1 diabetes before, so they don't really know what to do. Okay. And then, unfortunately, we've had experiences where the parent is just completely disengaged. So they might be doing work on their, I had a parent one time typing away on a laptop during an appointment. They're on their phone. In these situations, if the teen is old enough, so 16 and up, or just really emotionally mature, you can just ask the parent to step out, and engage with that teen individually. I've had to just ask parents, you need to put your phone away. Um, ask them direct, open-ended questions, such as, what questions do you have for your provider today? So that kind of requires them to come up with an answer and put their stuff away. And that can be frustrating for a lot of providers, but hopefully there's a way to get around that while also making sure that the parent's engaged and doesn't become defensive or resistant. So those are mine. I don't know if anyone else has any other experiences that I'd be happy to kind of problem solve. Doesn't look like it though.
No, we got one question about Zoom, but
Okay.
so okay. Since there's nothing in the chat or the Q&A, I'm going to assume that nobody has questions, and we can go ahead and wrap up a little bit early today. Genevieve, thank you again. Appreciate you coming and speaking on this. Next month, I have Dr. Meisinger, one of the psychiatrists at Children's, talking about substance use disorders. So if you're interested, you can join us next month on the third Thursday. I don't know the specific date off the top of my head.